friend and President-elect Dr. Rizwan Khalid, who's the speaker today. He's a cardiologist and his subspecialty is interventional cardiology and endovascular intervention. Advanced cardiac electrophysiology and device therapy. So he has done everything. These are the only subspecialties that I know. And so I think he has done everything. And institutions and designations are that he's an associate professor of cardiology in KCUMB. He's director cardiac electrophysiology Ascension via Christie Hospital, Kansas. And as I said, he's president-elect of APPNA 2020. And he's an AKU Khan University graduate of 1999. And we are really happy with him being the president-elect because we at Merit, APPNA Merit, we like when people like him come at the very top of the ladder in leadership, so that our education journey here and in Pakistan continues. So Rizwan Khalid, thank you. You can start, please.
Assalamu alaikum, everybody. Assalamu alaikum, Dr. Shahid, Rafiq, Dr. Danish, Bhatti. Thank you very much for the very kind introduction and the very kind remarks. So without further ado, we are already 22 minutes in. We'll get into the discussion. So I wanted to share a few things before we move into some of the questions. I will straight away tell my conflict of interest that I am not taking care, I have not taken care of hundreds of patients. So by no means you should consider me as an expert. I think in COVID-19, all of us are struggling to understand what COVID-19 is, its implication, and every day or two, we learned something new. And there's something that I learned this afternoon about COVID-19. So by no means I'm an expert. My older brother, Dr. Rizwan Khalid, is here. He's ID critical care in Toronto. He has seen much more patients, dozens and dozens of them. So I asked him for his help because I knew somebody is going to ask me an ID question sooner or later. So I need to have some backup support. So with that, I would go to the, I do not have any conflicts of interest related to this particular professional activity. Briefly, as the president-elect of APPNA, I would just very briefly like to tell you that what we are doing in addition to this very fruitful endeavor of APPNA Merit. We made an APPNA COVID-19 task force, which is chaired by past president of APPNA, Dr. Sajid Chaudhary, who is an ID specialist from Central Florida. He's chairing it, and he's helped by APPNA Social Welfare Committee Chair, Dr. Aisha Zafar, and both of them are doing a fabulous job with the help of quite a few other members from the Advocacy Committee and the Merit Committee as well, and Research Committee. So the relief efforts are done both in the US and Pakistan, which includes food pantries, procuring personal protective equipment, not just in the US, but also in Pakistan, and education and awareness, not just of clinicians, sharing resources, but also of the general public, as we are doing here. The APPNA Merit is a part and parcel of that clinical help to clinicians both here in the US and particularly in Pakistan. So this is just before coming on, I got the numbers for today. Total number of cases, 1,053,000 total deaths. In US, we have 245,000 with 6,000 deaths. In Pakistan, these are the reported cases. Obviously, I'm sure there is underreporting or under-testing going on. Pakistan has 2,400 cases with 34 deaths reported as of now. I do get a daily update from the Pakistani embassy here in the US, but which gives a division as far as the different provinces are concerned, but this is the overall situation. So obviously, this is the task at hand is huge. Um, so the first couple of days, we first did infectious disease by Dr. Sajid Chaudhry, who took care of a bunch of ID issues and general advices that was provided in that particular webinar. The second webinar was done by Dr. Awais Masood, nephrology and critical care, very pertinent subspecialties and subspecialists in dealing with COVID-19. And now the third is cardiology. And obviously in the future, we will have other speakers coming in, but we'll again focus on specifically ID, ICU, and hopefully microbiology and other public health issues as well. Today, I would very briefly talk about key cardiac issues pertaining to diagnosis and management. Since we do not have time, I'm just going to briefly tell you what I think are some of the things that cardiology gets consulted on or cardiology gets involved in. And as Dr. Shahid Rafiq mentioned, not only do I do general cardiology, I do interventional cardiology, endovascular work, as well as specifically working a lot in advanced electrophysiology and device therapy. And that is why the fourth thing will come into play at that point in time. So many of the presentations of COVID-19 can mimic acute coronary syndromes. We can talk about cardiac biomarkers and what is the, the utility of cardiac biomarkers and the prognostic value of cardiac biomarkers in patients with COVID-19. The prognosis with cardiac injury, um, hydroxychloroquine and azithromycin as a treatment, but my part will be what to do, how to prevent QTC prolongation, and how to follow that. And again, this question about ACE inhibitors or renin-angiotensin aldosterone antagonist agents and COVID-19. So I have a bunch of slides, but what I'll do is I'll just briefly, 30 seconds each, and then we will just open it to questions because I don't think we have a lot of time left. So COVID-19, initially the presentation, as all of you know, in and out, and one has to be asleep. Otherwise, we get some information on COVID-19 day in and day out. So the usual presentations are primarily respiratory. But again, shortness of breath is one of them, and we are called or consulted on pretty much all patients that may present with COVID-19. Cardiologists are involved. In fact, if you look at the series from Wuhan, China, amongst all the physicians, the worst physicians that got COVID-19 infections were actually cardiology. And one of the reasons in the beginning was that a bunch of these patients were having positive cardiac troponin, and these patients were sent to the cath lab. And over there, they were obviously, all the staff and the cardiologists themselves were exposed. So that is something that we did learn from that. So cardiologist, Dr. Muteen is here as well. I do not know if there's anybody else from cardiology, but that is something of interest to the cardiology community. So cardiac biomarkers are raised in COVID-19, and they could represent three different scenarios. One of the scenarios is in which we call stress-induced increase in cardiac troponin, which is primarily what we see, and the ICU specialist here will say it all the time. Patients that come in with sepsis or acute respiratory failure, there is a stress component which results in troponin leak, just like in pulmonary embolism, COPD exacerbation, pneumonia, or severe sepsis. There's positive troponin with that. So that one of the positive troponin is because of that. Secondly, COVID-19 or other viral infections similar to COVID-19, such as MERS and the first SARS infection. All of them showed numerous patients had myocarditis or perimyocarditis. So that is one of the other reasons why troponin could be raised. And then you could have the true acute coronary syndromes, in which these are patients that are COVID-19 positive, but then present with a true acute coronary syndrome. STEMI obviously is very, very easy to differentiate, but in non-STEMI, you have two group of patients, the type 1 and the type 2. Type 1 is because of plaque rupture, and type 2 is because obviously the stress of a severe systemic condition. So in general, again, this is not written in stone, this is not studied, but in general, the troponin I assay that we use, we have 2.0 is pretty much what we use. If it's less than borderline 0.1 or something like that, we consider that's probably type 2, and then type 1 is usually above 2. Again, this is my number. It's not studied, so please don't quote me on that. But certainly if it's a borderline elevated troponin, please, and the presentation is not suggestive of an acute coronary syndrome, please think about type 2 myocardial infarction, which is not due to plaque rupture, in which the treatment is treating the primary cause. Hydroxychloroquine is an almost has an anti, it has a sodium channel effect. It works on sodium channel like class 1A or class 1 antiarrhythmic agents. It also works on the inward rectified potassium channel. So it is associated with QTC prolongation. So therefore, maybe I can discuss later on what we can do for QTC prolongation and when to avoid giving hydroxychloroquine. And there are a few guidelines that we can certainly look into. ACE inhibitors, COVID-19, this was asked, I think yesterday or day before, I'm not sure whether Dr. Masood was asked or Dr. Chaudhry, but straightforward and small answer is that as of now, there is no data to suggest that we should stop ACE inhibitors or angiotensin receptor blockers in patients with COVID-19 per se, just because of COVID-19. Now, if they are severely hypotensive, obviously you're not going to give an ACE inhibitor. So if there is no other clinical reason to stop an ACE inhibitor or angiotensin receptor blocker, the recommendation by all the societies, the European Society and all the American societies, is that you continue ACE inhibitors and angiotensin receptor blockers. I guess what I will do is I will stop here and we can take questions. Thank you very much.
Very good. Thank you so much, Rizwan bhai. So we have a few questions already, and I'm gonna go through them one by one, and I will invite the panelists who have put the question to unmute their microphone and go ahead, ask their question, and make any comments that they might have. So I'll start with Dr. William Morton. Dr. Morton, please go ahead. Dr. Marie.
And I'm not sure if it's secondary to
sorry,
like
your
ARDS.
microphone was on mute. Please start from the beginning. I'm sorry.
I have been getting echoes on patients with suspected COVID, and I'm finding them to have LV dysfunction in the form of LV systolic dysfunction, which appears to be acute, but the LV pressures are normal. So I'm not sure if it's kind of a picture of ARDS-like, or should I worry about something else?
Yes, so this is typical in COVID-19. Again, as I mentioned, I've not taken care of hundreds of patients, but what is seen is that many patients in the early stages of COVID-19 will have a normal ejection fraction, and then they will go into fulminant acute respiratory distress, and then you will see that the ejection fraction drops, then they get into a lot of trouble. Patients that have decrease in their ejection fraction or have significant congestive heart failure or markers of congestive heart failure associated with ARDS do much worse. There is a series of 416 patients that was, I think, published in JAMA Cardiology. I think it's JAMA Cardiology, in which they looked at primarily at cardiac injury. And what it was very clearly shown that patients that have increased pro-BNP levels, they were checking pro-BNP levels, I'm pretty sure, and positive troponin, they did much worse than patients that had normal levels of BNP and troponin. So certainly that is part and parcel of that is cardiac injury secondary to acute respiratory distress syndrome, which results in a poor prognosis with these patients. In fact, I think they did their Cox proportional hazards, which showed that there's an increased risk of dying. The mortality is higher in patients that show any signs of cardiac injury. Coming to your question about whether the normal left atrial pressure with LV failure, we would presume that left atrial pressure should be high in patients that have LV failure. So certainly in a patient that otherwise doesn't fit the picture of you have normal or low left atrial pressure, you should certainly consider COVID-19 associated acute respiratory failure.
Very good. Thank you so much. I think there was also an interesting question that was raised by Dr. Mariam was about the social distancing or safe distance for patients. We talk about general social distancing of 6 feet, but what's the safe distance from someone who's infected with COVID-19? Is it 6 to 7 meters, which will be 3 times more than 6 feet, which is 2 meters, or is it 2 meters or 6 feet?
तो अगर आई थिंक मोस्ट पीपल कैन अंडरस्टैंड उर्दू, तो मैं इमरान खान की वो बात करूंगा. उसने कहा 2 गज का फासला रखें. ही इज अ क्रिकेटर, सो वो गज में बात करते हैं कि 22 गज की पिच होती है और ये वो, तो उसने 2 गज कहा था. 1 गज जो है वो 3 फुट का फासला होता है. So we are talking about 6 feet. I think that's the minimum distance. But again, like radiation, and Dr. Muti knows that as well, like radiation, we say the more the better. The further away you go, the risk of radiation goes down significantly. So, yes, 2 गज का फासला रखें, but, अगर आप उस hospital से बाहर हो सकते हैं, तो that's a better thing.
Thank you. I think it may be referring to a paper. There was a publication about distance traveled by the droplet based on the droplet size. So the heavy droplets drop closer to the person, and the smaller the droplet, the more longer distance it travels. And there was even a debate about very small droplets can actually suspend in the air for 2-3 hours before settling down or disappearing. Really small droplets. But I don't have the exact data, but I think there is some droplet size based distancing issues with the COVID-19. Not being an expert, I will skip there, but unless Dr. Raza, being an ID, have any comment on the distance traveled by the droplets. Dr. Raza, do you want to unmute yourself and make a comment?
Yes, thank you so much, Dr. Bhatti. So it's not the large droplets. The way it is that it's 6 feet for sure. I think that's something that we all agree on. It's not 6 to 7 meters. I think if it was 6 to 7 meters, no ICU will be able to, or no operation care will be able to take place. The other thing is you're talking about, so the smaller, so you see there's a major difference between how some of these droplets are spread. Like if you have the droplets like the tuberculosis, it's like a cloud. When a person coughs or sneezes, it's like a cloud that lasts and lingers in the air for a long time. And those are the ones that go into the body, and they can go into your deep down into the bronchioles. These ones, they're 6 feet. This data has shown it's very, very, the Chinese study that came out of 44,000 patients was actually very clear that they are very, very small and they just fall very, very quickly to close to the body. Actually, the most important thing was that the fomite was when you touch an infected surface, now it is seen that that's also very, very important. So this is just a clarification. I hope it answers your question.
Ji, thank you so much. I have Dr. Atika Rabia next, who has a couple of very good questions. Dr. Atika, please unmute yourself and go ahead. Ji, Dr. Atika, please go ahead with your questions. So there may be some microphone issues with Dr. Atika. A question was about GI symptoms in presentation in patients with the COVID-19 infection. And then a second question was in how many days patients recovering from mild to moderate and severe COVID-19, so what's the duration of illness before they recover in general?
Yes, if you want, I can answer it.
Please.
So, surprisingly, when the three symptoms that they talk about, fever, cough, and shortness of breath, actually we are seeing a lot of other symptoms. It's unbelievable. I don't know if it's specific for this. They are seeing that there's a lot of GI symptoms. In some studies, it has up to 30% patients have GI symptoms. But there is a discordance here. It's not oral or fecal-oral transmission, although the symptoms are there, and it can be isolated from the stool for a long time, even up to a month. What was the other question, doctor? About
the other question was the time it takes for healing from mild to moderate and severe infections. Duration.
Okay, yes. So that's very important question. If somebody is working in a hospital, healthcare worker wants to come back to work, what do you do? So there are two ways to deal with this. One is if you have testing available. So if you have testing available, that person should be tested 3 days after they are fever-free, and they should not be taking any antipyretics. 3 days fever-free without any medications, and the cough and shortness of breath should have subsided for 3 days. And then you check them for the COVID test 2 times in 24 hours. It should be more than 24 hours, more than 1 day. And if they are negative, you can allow them to go. And if you do not have testing available, which is the case in a lot of people, unfortunately, then what you do is you can, once the symptoms have subsided, they are saying actually in mild to moderate, if it's more for the mild, if it's 7 days out, you can allow them to go back. Actually, what happens is the WHO is very clear about what happens if a person is working in the hospital and they just recovered and they were not tested, because you know that there's a lot of shedding going on. You can still shed. Although we are not sure what's the significance of the shedding, is that that person should have a face mask and should have a face mask for 14 days and should not take care of immunocompromised patients. So this is something very critical in terms of managing these people who come back to work.
So I was reading somewhere that the patients who end up being in ICU ventilated, they may be in ICU for 50 to 60 days. Is that the typical disease duration?
Of course. Actually, not only the post ARDS complications are now taking a toll. Those ARDS complications, we are all familiar and we have seen a lot of patients. Actually, it's very interesting. The people who develop ARDS and severe COVID-19 are actually shedding the virus into months, into a couple of months even.
Rizwan bhai, do you have any comments?
Again, this is not my experience. I was just looking at some of the series in which they said that the mean time for intubation was around a week, 6 to 7 days. But again, if I can, ask the audience to please, if you can do the cardiac questions first, because you will have other opportunities to talk about ID and ICU. If we can focus on cardiology, we can at least answer those questions today. Thank you very much.
Thank you, Rizwan bhai. I see Fawad has a comment. Fawad, please go ahead. You can unmute yourself.
Yes, so I think Rizwan did said it right. We'll talk about it a lot, but I'll quickly go over so we can talk more on the cardiac. Regarding this question about ARDS, in general, with ARDS has three phases: the initial phase, and then the fibrinoproliferative, and then the fibrotic phase. So regardless whether it's COVID or non-COVID, recovery of ARDS patients in general can take 4 to 6 weeks or more. And we are still early in the process in the US. Of course, with the Chinese data, I have not reviewed it, how many, but most reports that have been there in general is 4 to 6 weeks. So I would assume based on that and based on just the ARDS itself, it can take 6 weeks or more for the full recovery when they go into ARDS. And then I'll leave it here so we can talk more about cardiac uh, manifestations.
Thanks, Fawad. So before I go to the next question, I see some new people have joined us. I want you to remind, please, if you have any questions, just type in the chat box and I'll try to get to them. Our speaker today is expert in cardiac failure or cardiac diseases and can answer any questions related to that with COVID-19 infections. If you want to make a comment related to this or your experience, please also either write in the chat box or you can also raise your hand. You can right click and raise your hand and I'll try to get to you as fast as I can. So Dr. Harikar has a question about ARDS and cardiac failure. Dr. Harikar, please go ahead.
Okay, assalamu alaikum. So I wanted to ask, how would you identify as in cardiac failure in patients who are already having bilateral infiltrates and high oxygen requirement? And do we, because we have a lot of patients who are coming in with comorbidities, uh, we have difficulties in getting echo because of the panic of the echo team coming over and doing it. There's a lot of panic at this point in Pakistan of different people coming and doing their part in the ICU. So we're getting there. We're trying to, get them the right PPs and the protocols for cleaning their echo machine and stuff. But still, we have an issue. So I also wanted to ask, what is the role of different biomarkers like proBNP? Should we be doing that when we are suspecting it? We don't have the facility of measuring swan gans or that sort of things. So how do we go about that? And we've had two patients who've had an STEMI and accelerated hypertension. These are the things that I've been facing and wanted an input from the cardiologist.
Okay, so let me start by, you asked about if the patient has ARDS-like picture, how do you differentiate between, or how do you make a diagnosis of congestive heart failure? So remember, there is a clinical portion of congestive heart failure, which is sometimes very difficult to distinguish between acute respiratory failure, especially in an ARDS kind of a picture, and congestive heart failure. Sometimes it is very, very difficult for us to differentiate the two. Also, even if you look at the CHF biomarkers such as BNP and proBNP, in many situations, the proBNP may be elevated even with ARDS without significant congestive heart failure. Since there is a stretch which happens, especially of the RV and the RA, and the BNP is released. So you will or you may see elevated proBNP or BNP levels with or without congestive heart failure. I would say, obviously, an echocardiogram it will tell you whether the EF is normal or not, whether there's significant diastolic dysfunction or not. Remember that many of these patients already have significant cardiac comorbidities. They have diabetes, they have high blood pressure, they may have cardiomyopathy, HOCM, adult congenital. All of these conditions predispose them to a worsening prognosis, and they may do worse, and their proBNP levels may actually go higher. So they may already have diastolic dysfunction. So obviously, if you have decreased ejection fraction, that will tell you that this is getting worse, or there is associated congestive heart failure, cardiomyopathy. However, let me say that the treatment should be of ARDS. The treatment should not be of congestive heart failure. If you aggressively treat congestive heart failure, there is actually you keep them on the drier side. So, you focus on the ARDS, not significantly on congestive heart failure. Your other question was about non-STEMI. I briefly talked about non-STEMI. You have to differentiate whether it is type 1 myocardial infarction or type 2. Type 1 myocardial infarction is due to plaque rupture. That is your usual non-STEMI. Your troponin levels are usually higher. And this is again my understanding. I'm not telling you of any randomized controlled trial. A troponin of 2.0 and above, you should seriously think about a non-STEMI due to a plaque rupture. If your troponin is 2.0 or less, it may be type 1. It certainly can be type 1, but it could be type 2. Type 2 myocardial infarctions are those acute coronary syndromes which are associated not with plaque rupture, but with stress induced or just increased supply and demand issue. Remember that you can also have positive troponins in myocarditis as well. So I'm not sure if I've missed any of your questions, but pretty much heart failure, non-STEMI, I think these
So
are.
I just wanted to ask, so again, two things. If you are having an ST elevation MI, have you been intervening in these patients as in going in for a cath with patients who have COVID?
Very tough situation. I'll be very honest with you. The first day I was on call for 10 days, and we had an 86-year-old lady who came from the nursing home. She had the cardiac comorbidities. She came in with acute respiratory distress. Like, she came in with shortness of breath. I was very, very concerned. She had anterolateral ST elevations, but was not complaining of chest pain. I was very concerned. I tried to convince the ER attending that we should not be doing this, and somehow she's 86-year-old, maybe we should. Unfortunately, in the state of Kansas, it takes 24 hours before we get the test positive. So there is no rapid testing at this point in time. So you cannot, in a STEMI patient, when time is muscle, you cannot do a quick test like the Abbott test that's coming out for 5 minutes, get a result, and then move on. So I tried to convince the ER attending that we should not do it. However, we ended up doing it. We found it was a subacute infarct. The patient infarcted 3 to 4 days ago because we found that the troponin was 80. So long story short, in STEMIs, one of the things that if it's a confirmed COVID-19 patients, you may consider thrombolytics and do only PCI if it is a rescue situation in which the patient does not respond to thrombolytics. So that is certainly one of the things. But again, this is not guideline. This is just recommendations that people, or it's a consensus statement amongst 5 cardiologists that sit and they said, you know what, we should just do fibrinolytics. And if the patient still continues to have chest pain, we do a rescue PCI. The risk in the cath lab is very high to the staff and to the cardiologist. So that should be taken into consideration.
Very good, thank you. I have a few questions and few people in the queue, so I'll try to keep going and get them one by one. So I have Dr. Noor Mahal Kabani next, and please also introduce yourself, as I apologize, I was not able to get to you when we were doing the introductions. Please go ahead and unmute yourself, introduce and ask your questions and make your comment.
Yes, this is Dr. Kabani. I'm a pulmonary critical care physician in Houston, and I am doing telecritical care across several states in the country. So my question was about the component of myocarditis in these patients. I know that coronaviruses the other coronaviruses cause fulminant myocarditis in some patients, and the treatment for that is high-dose steroids. I'm just wondering whether there is any data on myocarditis in COVID-19 patients specifically, and if so, do we then treat them earlier with steroids, unlike the recommendations for COVID ARDS currently?
So Dr. Kabani, again, if you look at on JAMA cardiology, there are a few case reports in which they have looked at myocarditis, significant myocarditis in patients with COVID-19. In patients that had other coronaviruses such as MERS, there is definitely a component of fulminant myocarditis. Coming back to COVID-19, there is actual direct injury of the myocardium due to more than one mechanism. either direct injury or injury due to significant inflammatory response. So the treatment should be of the primary cause, the inflammation as such. And treatment of myocarditis, again, I cannot speak about use of steroids because I have not. So I would let, if there anybody else can want to take that question, that's fine with me. I will tell you that in fulminant myocarditis, which is associated with significant hypotension, these patients occasionally may need hemodynamic support. And that's again a problem because ECMO is not very widely available even in the US. So that is in fulminant myocarditis, significant hemodynamic compromise, ECMO is one of the recommended modalities which may help. So if somebody else wants to answer about steroids in an acute myocarditis, that's fine, but you treat the primary cause, which is the inflammatory response.
I suggest not using the steroids in this in COVID patients for sure.
Okay.
This is, can you hear me?
This is Awais Masood. You guys hear me?
Gigi.
Rizwan, this is Awais Masood. So I just have a comment. We are actually in the epicenter of COVID infection, and it's a big university hospital, and we have a cardiac fellow and a lot of cardiologists. But you're right, we are seeing patients who are coming with COVID infection, and they have, looks like they have acute injury, cardiac injury going on. And I have never seen in this hospital patient getting thrombolytic therapy. So this is the same reason that these patients are getting thrombolytic therapy who come with the, even STEMI or acute coronary injury. So probably that's the same reason that you described, that thrombolytic therapy could be a better option when PCI have a lot of complication and risk, particularly spreading the infection.
Right.
Fawad, please go ahead with your comment.
This is Khalid.
Yes, so I can just put a comment regarding steroids. So for mild to moderate COVID infection, even intubation with acute lung injury, but not in ARDS, both WHO as well as CDC guidelines suggest to go against steroids. That's number one. Number two, there is a plenty of data in ARDS, non-COVID ARDS, which goes against the use of steroids, especially in the first 5 to 6 days. That's number two. Number three, SCCM, which is Society of Critical Care Medicine, they have their recent recommendations. I think somebody's gonna go over it someday as well in Surviving Sepsis campaign as well. And they have put out weak recommendation for giving steroids for severe ARDS associated with COVID. Now, this is very controversial. Most centers are not doing it, but rather doing TOSI and that with good effects. But I wanted to throw it out there. I don't know how's F.A.C.P.'s experience there, but in our center, of course, we have much lighter load. We are staying away from steroids, but I know some centers in New York are considering steroids for very severe ARDS. But that is separate to myocarditis. I don't know if we need to use just for myocarditis. It is just for very severe steroid, very severe ARDS, and that is again controversial.
Kaleem bhai, please go ahead.
I think I totally agree with Fawad. Yeah, I'm going to go over that, but yes, myocarditis or not myocarditis, if somebody in a refractory shock and you are exhausted all your arsenal, including your vasopressors, and patient is still in shock, then there is two places. Number when in the shock, then they are recommending using the low-dose corticosteroid, which is about 200 milligram of hydrocortisone, either in the infusion form or in divided doses. And it is a weak recommendation, but it is a recommendation on the basis of the data. And in the ARDS also, there is some, and I'm going to go over with that detail, but right now for the severe hypertension in a severe septic shock, yes, but a weak recommendation.
Yeah, this is Awais Masood. Yeah, in our hospital, we also using a steroid, but again, as a last resort. Some patient, not everybody, but we are using some patient who are have used everything else and just as a last resort.
Dr. Kabani has a comment about it too. If you want to say, Dr. Kabani. Okay.
I was just saying that I agree with everyone else who said that steroids they're not recommended, especially not recommended in the viral replication phase, which is the first phase of the disease process. There may be a role in the proliferative phase in some patients, as Fawad said, much later, or as a last-ditch effort. I asked people at Methodist in Houston about whether or not they were using it. I think out of 24 or 25 patients they used it in one patient as a last-ditch effort in a patient that was in shock, as you all said.
Thank you. I think we're starting to run out of time, so I'm going to try to quickly go to other people who have questions, so we're able to take them too. Dr. Abdul Naeem, please go ahead with your question and comment. Dr. Naeem, Abdul Naeem. Okay, and then I have a question from Dr. Zishan. Dr. Zishan Ahmed, please go ahead.
Assalamu alaikum. My question was, when we are giving hydroxychloroquine to a patient and there is a QT prolongation, how to manage that? Just to hold hydroxychloroquine or something else?
So, Zishan, what was the QTC of your patient?
No, we have not yet got any patients of COVID, but our hospital is preparing to receive patients. I'm here just for learning so that.
Oh, okay. So I thought maybe there was a particular patient. So, usually, if you have a baseline QTC prolongation of around 450 to 470 without a bundle branch block, you should seriously consider not using it. With a bundle branch block and 500 milliseconds, that's already too much. So you certainly have to, make sure that all the electrolytes are okay, potassium over 4, magnesium over 2, and the patient is not on any other QT prolonging agents, especially neurological medications such as antipsychotics. All of those do cause QT prolongation. Patients that have congestive heart failure obviously are more likely to develop QTC prolongation. So the baseline QTC is very important. Any increase after the first day of more than 50 milliseconds, it's something that you really look at, and you should strongly consider discontinuing it. It's a pros and cons, whether the risk is more than the cons. The other thing is monitoring. So you can do telemetry monitoring for QTC, daily EKGs or twice daily EKGs, and then you take it from there. But certainly once you go over 500 milliseconds of your QTC, corrected QT, then there is a risk of torsades de pointe.
Thank you. Dr. Abdul Naeem, you had raised your hand if you are there, and if you have a question, please go ahead and unmute yourself. I think we have covered all the questions that were put so far, and we're already 5 minutes, almost 5 minutes over time. If someone has any questions or comments, please raise your hand and let me know. Dr. Naeem, please go ahead. Okay, Dr. Awais, I see you unmuted. Please go ahead.
Yes, I have a question from Dr. Rizwan. Rizwan, these patients who develop myocarditis and their EF drops very quickly, is there any role of, like for the time being, any inotropes giving those patients any Milrinone or even dobutamine just for a few days? And if, generally it does not improve, survival on other patient, but in this who has acute myocarditis or low ejection fraction, any role of inotropes?
So let me tell you, in general, COVID-19 or no COVID-19, patients that have acute myocarditis and develop severe hemodynamic compromise, their prognosis is horrible anyways. We usually, they are sent to a transplant center. They may require LVADs, and they may, require some advanced therapy. So that is in patients that have myocarditis, viral or non-viral, you throw the kitchen sink at them. You give them whatever it requires, whether that is vasopressin, whether that is levofed, milrinone. You choose your poison, and you give them whatever you can. I thought you were going to ask whether you should use a balloon pump or an impeller device. So you can certainly, LVAD or impeller devices for hemodynamic compromise, you can use it, especially LVAD. However, in a COVID-19 patient, the risk to the cath lab staff and to the physician is definitely something that you have to consider in patients with significant hypotension with severe myocarditis. So that is my 2 cents about that.
Does anyone else have any questions from the speaker about cardiology and COVID-19 infection? Please unmute yourself or raise your hand.
Yeah, I think this is Fawad. There's a very basic question for you regarding ACE and ARB. Do you think, because in earlier reports there was some suggestion of virus with some predisposition to the ACE receptor? So 2 questions. One is basically ARB will be protective, ARB, since that will block the receptor. And secondly, have you seen any kind of right heart failure specifically associated with the COVID infections?
Okay. So, Danish, before we finish, I have a question for the panel as well, and I would like to see what the panelists have to say about that. But let me take Dr. Chaudhary's question first. So, in patients that have COVID-19, number one, you asked about ACE inhibitors and angiotensin receptor blocker. Dr. Chaudhary, it's too early to say something about it. I'm just going to go with the guidelines. The guidelines suggest that the benefit outweighs the risk at this point in time. They're talking about, if you look at the ACE receptor, it is expressed very significantly in the lung tissue as well as in the kidneys and also in the heart. And
Right.
they're talking about that the ACE2 receptor is where the COVID-19, attaches and goes into. Patients
Right.
that are on ACE inhibitors or angiotensin receptor blockers, there is an overexpression or a proliferation of other ACE enzyme or ACE receptors. And they are talking, there's a thought about whether that is the reason why some of these patients that have diabetes and hypertension and congestive heart failure that are on ACE inhibitors, maybe that's the reason why they're doing worse. However, there are other reasons why they're talking about killer cells, cytokine release, and type 1 and type 2, which could be the other reasons why these patients are doing worse, typical ARDS kind of pathology. At this point in time, I obviously cannot recommend, none of the societies recommend that. So the only reason when you will stop it, ACE inhibitor or an angiotensin receptor blocker, is if you have hemodynamic compromise, and you would have stopped it in any hypotension
Situation like that.
anyways. Danish,
Very
I
good.
have a question for the rest of the group,
Ji,
if
please.
every question is being done.
Yeah.
Ji, please go ahead.
So what is the thought of the group about hematological abnormalities, especially a DIC or a TTP-like picture? They're talking about, I was looking at reports of microvascular obstruction because of both hemolysis as well as thrombosis, like almost like a DIC TTP picture. Obviously, in that situation, TPA is probably not the right choice. But what does the group think about heparin or enoxaparin in such a situation? Have you seen that?
Okay, let me, in our hospital, we're seeing a lot of patients with the COVID, and both are risk hemolysis and also thrombosis. So I think we have more problem with the thrombosis. So we have a low threshold to start patient on heparin on this patient. and we have been doing it.
Yeah, this is Fawad. We do not have as much exposure, as of course in New York and New Jersey and West has. But with the reports, and this is what our strategy is as well, to have a very low threshold for starting heparin in those patients, based on the various reports that we've read.
Quick question. After you've recovered, what is left with myocarditis? Is there any residual damage to the lungs and heart, or you recover completely?
Patients that do bad, do really bad. Patients that will recover can have a complete recovery. Now, this is what is usual in viral myocarditis. If they recover, some of them are so bad they may need transplant or they die. But the patients that recover usually, again, it's my opinion, it's complete recovery.
There's also a question from Dr. Afzal, Muhammad Afzal. If you want to go ahead and ask your question.
Yeah, this question is basically encompass pretty much everything which we are doing right now. It raised an ethical question, and goes back to the speaker's first encounter. The patient comes in who is very highly you're suspecting very highly that it probably is COVID-19 infection. And unfortunately, those days, test results were coming back 3-4 days. Currently, we're getting within 16 hours. But so, do you take the patient to cath lab and expose, a big, vast majority of people, and doing procedures are very well described as a high risk to the providers as well as to the technician, etc. In an 80-something years old person, so why not use TPA instead of taking cath lab? And similarly, somebody earlier asked about Swan-Ganz catheter, and my bias would be definitely not using unnecessary procedure. In fact, what we do in our institute is we avoid all the unnecessary procedure, or even some procedure which on normal days probably we would do, but if it is not absolutely necessary, we wouldn't do. Similarly, batch the labs. Similarly, bronchoscopies, etc. Only do it if it is absolutely necessary. And this is not something which I am suggesting. I'm just opening some conversation from some other colleagues who have a lot more experience in New York City, etc. So I'll leave it there. And
so, Dr. Afzal, I would quickly answer the TPA, and then maybe others can jump in about the Swan catheter. TPA, as I mentioned, that is a recommendation that we do want to give TPA to as many patients as possible. And we are very cognizant of the risk that our staff and the cardiologist take. In fact, if you look at the series from China, cardiologists were what the physicians that had the most COVID-19 infection. One of the reasons was so many people having positive troponin, and they were taken to the lab because they didn't know any better. However, after China and in Italy, we have much better experience, and certainly medical therapy, aggressive medical therapy is what I recommend. If you have to still use it, you do it. The indications of SWAN have significantly gone down. I'm pretty sure you are hardly using it in your institution as well. So we hardly use a SWAN, and I would not. Otherwise, there's so many other ways of finding out the information that you get from a SWAN. So we won't recommend it. So I would like to hear from others as well. Thank you.
Yeah, this is Vas Masood. As we earlier spoke, in my hospital, I have not seen anybody getting TPA until now for acute coronary injury. And pretty much most of the patients who are coming with the suspected COVID-19, the acute kidney injury, and who otherwise would go to cath lab, they are not going, and they are getting this thrombolytic therapy. As for the SWAN is concerned, that I'm an intensivist, I used to put like a routine 10-15 years ago, but I think the last SWAN as an intensivist I have not done. Cardiologists still do that for right heart cath for other reason, but most of the time that's not any emergency procedure. We have so many other gadgets now. We're using Cheetah device. I'm sure other people are using also. That gives us pretty much all the information Otherwise, I mean, Swan would do that.
Yeah, this is Fawad. I just want to reinforce quickly what has been said. Swan is kind of out for the management of septic shock now, and flow track, Theta, and Echo itself has been used quite often. Now, regarding COVID-19, we are trying to minimize exposure and time spent in the room as much as possible. So even one echo, a quick echo, or a focus, which is basically a limited echo by intensivist, which we usually do for shock, we are kind of holding back as well on it and going with the clinical parameters. But at the very least, if things are going south, then we go and do the echo to see the IVC and other thing and combine for the shock element. That's regarding the SWAN. So I think that indication is kind of out, other than post-cardiac surgery, which is a separate topic. Regarding procedures as well, that I'll talk when we go a week or so down. There was another paper written by some people in Stanford. As Rizwan mentioned, there was a high morbidity in the cardiologists. There was a high mortality in the ENT surgeons and people dealing with airway in both China as well as in Iran. So there was a procedure done in China with 10 ENT staff. All of them got infected, and the fellow died in 24 hours. After that, our hospital stopped all the bronchs, rigid bronchs, and the cancer, unless it's an urgent cancer or an urgent bronch or urgent intervention. So I would just say that be very careful with any bronchoscopy as well. We are trying not to do even in the neutropenic patients and trying to go with the clinical. The worries by cardiologists and everybody else are true. The amount of time you spend in the room, in the airway, or in other procedures is directly proportional, if the patient has COVID, to the chances of exposure and attaining that virus. I'll stop there.
Thank you, Fawad. So I think we're way above time. So because we want to do this every day, let's keep the energies going and take a break here for today. I will hand over the microphone to Dr. Shahid Rafiq for closing. Shahid bhai, go ahead.
Okay. Okay. Now I'm unmute. Thank you, everybody, again for a wonderful, spirited discussion. Thank you, Rizwan, for bringing this important new dimension to the management of COVID. Like all the important organs are being involved, I have not heard if the brain is involved or getting involved, or encephalopathy. So maybe then neurologists will also jump in. But thank you guys, everybody from Pakistan, from here. We are really thankful that without your presence, without your spirited discussion, participation,